Well, even not as they have a couple more processes that they can go through. So we'll actually start hearing before they'll have it in January.
Everybody back in place. Okay, well, we get to transition into what should be fairly new for a lot of you. It seems like we've got some of the flight crews here that have been given electronics, which is great. So, it's always great in a team if you have resources. It's interesting coming down here to Fort Bragg's neighborhood and not having a lot of former military in the mix, because we don't have a lot of military up where I am in Hartford yet. In our blood program, we've got 3 from military that are either in reserves that have been trained in blood. So they've helped their colleagues out and when new people have come in, but now all the medics are up to speed. So you've got some good resources here with the air crew, it sounds like. So we share and lean on each other when we've got questions. So I'm going to transition the talk now into really kind of understanding blood, because again, if you haven't been around this, you hear the words component and whole blood, and like, why is there even a difference, and what is the difference? So let me do my best to explain this to you. Think of blood as its own organ system, okay? So within it, it's got multiple components that are sort of balanced, okay? So we've got red blood cells whose primary job is to carry the oxygen to the tissue. We've got plasma, which is the liquid part that suspends the red blood cells to get it out to the tissue, but it also contains a lot of proteins and clotting factors. And then we've got platelets, and platelets are the cells that form the initial plug when they get in contact where there's been bleeding or disruption of the epithelial lining of a vessel. So they kind of start the process. So you can see in a hemorrhagic shock patient, we really need all of those back into the patient as quick as we can, because that's what you bleed out. So in spite of where we stand with all the years of research in something, the holy grail would be, do we have a synthetic blood substitute that does not have to be temperature stored and type specific to the patient? And there's been attempts over the decades to get there, but we've never gotten there. We don't see it in the foreseeable future. So that's why even with DOD, we're going back to whole blood, because that's what the patient lost. Even all the attempts to synthesize something that would be like a clear fluid would be to carry oxygen, but you really can't match the job as we stand today with something we're manufacturing. Now, biotechnology may get us to some point where we've got an artificial blood product, but right now, and for the foreseeable future, we don't have that. So, if we take whole blood out of our body, we just draw a tube, and we spin it, that separates the components, that's called centrifuging, and we would see what looks like exactly like this little cartoon here, is that the biggest part of it would be plasma, that would look yellow, and that'd be about 55%, that's the clotting factors in the liquid portion of blood. There'd be a thin layer that would have white blood cells and platelets, and then we would have the red blood cells, which would be about 41%, which is the oxygen carrying capacity. So when a patient or a donor goes to a blood center and donates, the top left is what the unit of whole blood when they donate comes out, it looks like. Then if that's spun, you can see that separation I showed you on the previous screen where we get that layer on the top that looks yellowish, and that's the plasma. Then this buffy layer between the plasma and the red blood cells has got the platelets and the RBCs, and the darkest maroon is the red blood cells. And then those get separated out into components. This is the traditional way, okay? So they go into 3 separate bags. We have 3 separate storage requirements. Platelets are only good 5 to 7 days and should be kept at room temperature. Plasma typically gets frozen and thawed when it's going to be used, although there are systems that carry thawed plasma, but it's just a very short shelf life. And then the PRBCs. And shelf life matters basically on what kind of a preservative is in that product. So this method is a very efficient way where we could take one donor, split the donated whole blood into components, and treat multiple patients for multiple conditions, and it makes sense for medical patients. And this came around in the 1970s, this big turn in blood banking, because if you think about it, if we have an oncology patient and we're giving chemotherapy, and the only thing that they're lacking is platelets, then that's all they need back. If the only thing they were lacking is that their red blood cells are low, that's all they need back. They don't really need whole blood. If we're correcting a clotting deficiency, plasma can be made into 15 different products to address clotting issues. And typically when we have more patients on Coumadin, historically, that's one of our reversal agents when they're having to bleed. But this really falls short for hemorrhagic shock, because remember previous slides, we said we basically want to get back to that 1-to-1-1 ratio when we're resuscitating in a massive transfusion. And now we've got 3 bags. Every one of those bags has got a preservative, which is an anticoagulant. Every one of those anticoagulants can bind to calcium and lower a patient's calcium level. So this works great from the 70s forward as far as allocating our blood resource when we separate it into components. But whole blood has a product starting to vanish in the 1970s. So when we look back in pre-hospital care on a longer scale, any transfusions or infusions pre-hospital were essentially in the domain of the military until we developed, civilian EMS in the early 70s, advanced life support. But in all the conflicts leading up through Vietnam, it was whole blood that was used as resuscitation. For a short time in World War II, they attempted plasma but noted a trend in mortality, a negative trend, so they went back to whole blood. And about the time Vietnam ended was this next era of component therapy. And for 30 years, we basically have relied on clear fluids, LR, crystalloids, saline, until we got into the first 3 years after the big conflicts that started in Iraq and Afghanistan to look at phasing back in blood products. So it's kind of one of those back to the future things, almost like IOs, right? They used to use IOs on adults and was kind of unheard of until we got to the recent. We used to use tourniquets, unheard of until the experience from the military. So, up until we've come to this point we're at now is that, we give the clear fluids, way too much of it, and then later replace the blood components based on lab values. So even in trauma centers, it's just not a common thing to have whole blood available. There's a demand signal for it, but it isn't, and most of the blood collection agencies don't have whole blood available to provide. So you're lucky when you're in a system like here, like David was in Onslow, and like I am in Hartford, because the first thing that we looked at is, can we even get whole blood? And I knew in our system, based on my plug into other places, that the Red Cross had made a stand and said, we, based on San Antonio, the STRAC and DOD, and this demand signal that we think is going to come from EMS, we're going to actually start making whole blood more available, which is kind of funny because the way Dr. Kapp explains it there from one of the slides I borrowed from him, it's like all they got to do is just collect the blood, walk by the centrifuge, don't do anything with it, just package it and send it to the hospital. And that's essentially what they do with it. But from a blood bank perspective, economically, they don't want to do that a lot because all the other medical patients which have a higher demand for the components. So they weigh a balance, but we were lucky in our neck of the woods because the Red Cross had already started providing whole blood, so it wasn't like we had to push it much. So now it comes back to what is wrong with saline and LR, and I think you've got a program that you've already sent out about this. The high points of that, if you haven't seen the learning module on the evolution of the fluids, is that we go back to normal saline, and if you listen to some of the thought leaders in San Antonio, their analogy is like if a patient's in the lethal triad of acidosis, coagulopathy, and hypothermia, giving room temperature normal saline to them is akin to throwing gasoline on the fire for the patient, that you're just going to make it worse and you're just going to burn them out and kill them. And there's some truth to that. I mean, I think the way that they say it has to be a little bit balanced, because if all you've got is some crystalloids and you've got a head injured trauma patient, you can do hypotensive resuscitation, bring their pressure up enough to try to at least give them a good neurological outcome. But you have to have this awareness as a pre-hospital provider and any provider in hemorrhagic shock care of what these products actually do when they're given in excess. And as I said before, this will temporarily expand the volume and temporarily raise this hydrostatic pressure in the vessels, but the unintended consequence of that is that you can dislodge the early soft clot that's forming and create a rebleed. It may maintain a little hemostasis when they're in a hypotensive state and you haven't diluted their clotting factors. Any additional food you give that's not blood containing those clotting factors is going to dilute the clotting factors that are already there, and also remembering the clotting factors that are already there are being consumed to form the clot and maintain them. The pH of normal saline is not normal, it's 5, so it's acidotic. Lactated ringers is about 6, so it's a little better, but still not at the normal 7.35 that we like to see. Long-term studies on larger volume of normal saline, like with sepsis, shows that it's an inflammatory agent and it causes renal damage. So this Thor network is something I would point you to as a great learning source. They actually have a module for pre-hospital blood administration. There's a lot of great lectures. It's free. You just sign up. It's the Trauma, Hemostasis, Oxygenation Research Consortium. It's based in Norway. That's why it's got the cool name of Thor. But it's a joint U.S. and Norwegian venture. And Dr. Spinella is a pediatric intensivist who was deployed downrange in the early days around Fallujah, and he's one of the service members who is kind of credited with bringing whole blood into a field hospital. And back then they started calling whole blood Jesus juice because they would see such a change in the patients with a small volume of blood, like it's raising the dead, so to speak, not to be disrespectful. But that's, if you ever hear that in the military vernacular. And then he coined a really good phrase because he's got a strong stance against giving away from those crystalloids. That blood is for bleeding, but salt water, like saline, is for just cooking pasta. It doesn't really have a good effect in medicine. So again, to keep this simple, we have been for years taking whole blood, separating the components, diluting it with anticoagulants. And what we've come around to realize after these recent research is that we need to keep whole blood the way it was and give that to the patient, and it's all in one bag, so it's very simple. We just give whole blood. And there is a difference between whole blood and the components because we end up diluting the components. So our hematocrit, which is the cellular component of the blood, drops down to 29 when in a unit of whole blood it's 35 to 38. The coagulation factors drop down to about 69% of the pre-collection levels. In whole blood, it stays at about 85%. And then platelets that are collected and stored with a preservative would have about a 90,000 count, whereas platelets in a whole blood are going to mimic what we have circulating, and it'll range from 150 to 300,000. So this starts the clot. This has got the clotting factors to build the bridges and maintain the clot, and this is going to carry oxygen. So we've got it all in one package with the whole blood. The question is how can we not know the patient's blood type? This is something that's worth reading. I'm going to just pick it up as a reference line, but we are very safe giving group O blood to patients. So when we give group O component, just red blood cells, it's really the fact that it's not going to have the antibodies because there's no plasma in a typical unit of red blood cells. And there's no antigens in it. So you can give this to anybody with type AB or AB and not expect a transfusion reaction. When we step up to whole blood, we haven't taken the plasma out. We want the plasma in. We're giving it to the patients. And in the plasma, we do have some levels of anti-A and anti-B antibodies in the plasma. So if I was to give a unit of group O blood and the level of these anti-A are high enough and I give it to a patient with group A blood, is that I'm going to start to hemolyze the blood in the patient that I'm giving it to. So you will see this LTOWB, which is low titer O whole blood. That'll be on the blood that you get. And that refers to the titer of the anti-A and anti-B that's carried in the plasma. So there's a method of detecting this and looking at it. And it will usually be on your bag here that the titer level will have been checked. And this is something your blood bank may or may not check with you, but it should be listed on there to know that the whole blood has a certain titer level. Most places will accept less than 1 to 256. Some blood banks, like I believe it's Pittsburgh, wants theirs to be less than 1 to 100. But the hundreds of thousands of patients in the military experience have gone to this titer level and not had any significant reactions or hemolysis. So it's very low risk. We don't need to know the patient's blood type. We carry the type O blood. When blood goes into the blood bank, I don't have a picture of ours, but usually there's a sticker put on it that our blood bank, when it receives it from the Red Cross and they say, this is a Group O blood bag that we're sending to you to use in your hospital, they actually take a sample and they test it and they confirm that indeed that is type O blood. So that's like one of the first safety gates here to make sure that something didn't get mislabeled at the Red Cross, and they put a sticker on it confirming it and they scan that in. So we know that what's in that bag has been at least checked twice, and if there's any discrepancy, the bag doesn't go any further. And then when our medics come to pick it up, they do a check with the blood bank to make sure it has that sticker on it that says that that blood was checked and that indeed they're receiving no positive unit. Then when they're at the scene and they go to give it, they look at it again. So we're trying to make it so that, that Swiss cheese effect, that we line up all these errors, doesn't happen. So the biggest errors that happen really aren't with this emergency release O positive or O negative blood, type O blood. It is more the errors happen when we actually have an elective type transfusion or one that we've typed and screened the patient, because there's more steps to that. We could mislabel the original specimen for the patient, and we're giving it to the wrong patient, and we're giving the wrong blood type, and that's where we can get the fatal reaction from. But as far as emergency release with these steps, we're very safe with what we do. And up until recently, and part of the reason why, to understand why whole blood is not available throughout the country and throughout the world, is that the American Association of Blood Banks actually did not have a policy until the Thor group and the San Antonio group actually petitioned them with all the research to say that low titer O whole blood is accepted by the American Association of Blood Banks to be released as a product. So until then, the blood collection agencies just had to do this kind of under a special program to do it. So there's some transfusion reactions that can happen, and they usually happen fairly early on. There's mild allergic, and it's usually a hypersensitivity to something foreign in that unit of blood that's being given to the patient. And it can be as severe as a anaphylactic type reaction, but you basically treat it the same way. The normal way you would treat an early allergic reaction or an anaphylactic reaction, MD, Salumedrol, Benadryl, whatever's in your protocol. There's some later reactions, like a septic reaction, and this is usually by bacteria that's already grown in the blood that may contaminate it, but that's a very low occurrence issue because of the cold storage chain that we do with blood. Blood that's outside of the temperature range is more prone to develop a bacterial infection and have the endotoxin. The dreaded reaction is this acute hemolytic transfusion reaction, and again, this shouldn't happen in any of these pre-hospital systems because we have enough checks and balances. We're more at risk with a hospitalized patient and straight out human error, either on the collection end and mislabeling the specimen, or just going to the wrong patient with the wrong unit of blood. So going to where we are today, it's important to understand where things came from. And for your learning from this point forward, I think that this is a great resource. This is that Southwest Texas Regional Advisory Council. And I told you, remember, it's a big part of the state down here in the southwest part of the state of West Virginia. And these are the folks that, with a joint funding effort with DOD, with San Antonio Fire on the lead, is the ones that developed this methodology of either you take the blood, you put it out on an EMS vehicle or a HEMS vehicle, and you put it out for about half of its shelf life, and then you rotate it back into a mothership hospital where it'll get used, or you split it into components like the plan is here. And this works really well to minimize the waste of the product. I have talked to so many systems across the country because of the work I do with the warmer and life warmer, and I get a window on all of them. Early on, some of them, they would literally get blood, and these are some major name systems you recognize, HEM systems, and throwing away about a third of it because they weren't using it, which is just unimaginable when we're asking people to donate blood and know that we might throw away a third of what's donated. So this system works. It gets it back into the hospitals. if you have enough hospitals to rotate it through, or if you have an active blood bank that's going to split it in components and it gets used. I think everybody is, because of the light of day that's been shown on this process here, is switching to a process like this so that we're not seeing this waste. One of our users in Houston buys it completely independent on a ground EMS system, but they usually transfuse 2 a month, so they even have minimal waste, but they just buy it directly and they don't rotate it in, but just their volume supports what they do. This is the Strax webpage, and there's a great video from Dr. Jenkins, who's a former, I believe, Air Force trauma surgeon who's down there, and he really goes through a great question and answer. I think his nursing students, Dave, that are next to him or something, and they get to ask him questions about what is whole blood, why do we use it, what are the, it's a great Q&A on whole blood, so I definitely would have you take a look at that. So the local, you've got all this set, you've got your local blood bank, your pathologist, the EMS system, your medical directors, your EMS chief, emergency department, trauma service, all on board with this. And then usually the big stopgap here is the pathologist and the blood bank. And they have a big job. They have to maintain the safety of blood. So it would be unimaginable in the days that I started in EMS in the 80s that we would ever carry blood on ambulances, on ground ambulances. But, we've come to this point where we have very reliable cold storage temperature devices here that we use that can maintain blood at a certain temperature. And then we've got inexpensive $150 temperature monitor that goes by Wi-Fi and can notify all of us of when the blood's getting out of range. And then on the blood bag itself, there's little temperature dots on it that will tell you if the blood unit did get outside of range. So there's belts and suspenders, I like to say, as far as the safety net for carrying the blood. One of the things about the stewardship, and we haven't been good about this in our neck of the woods, and I think COVID has made some issues with donations, but this Brother in Arms program that San Antonio started is interesting because they would screen typo donors for the low titer. They get their own app on their phone, and then the blood collection service, when they're low on low titer O, page them, and they really feel invested in the program and the community. So other systems have adopted this. Victoria Fire Department is one that I work with also, and they stood up a blood program, and they're kind of between Houston and San Antonio, but they brought the Brothers in Arms program out. So the blood bank, totally loves that when we have public safety, and a lot of people support if there's a call out from public safety to keep replenishing the blood supply. But overall, we really feel that theoretically, that when we do this with ambulances, on ground ambulances or HEMS, they're transfusing patients that are normally going to get transfused anyway. So it's not like we're using blood that wouldn't be used anyway. And really, it looks like we probably better resuscitate the patient, so we may not need to use as much blood. So there's some studies coming up that are going to look at all of this, but it just seems to make sense. So, we see this happening in very rural systems, 110 miles from ground from the trauma center. This is the group in Houston that we work with. They gave their first unit of blood 6 hours after that picture was taken when they first got it. There's just no telling when you launch here in Cumberland how long it'll be until you get your first unit. That's some way to mention, David. That's always the anxiety producer, right? So how long did Onslow take before?
30 days.
30 days. Wow. All right.
The trauma flatline.
Yep. We took 12 days in Hartford to get there, and every day it was like, okay, when are we going to get the first? San Antonio Fire, 7th largest city in the U.S., went 6 or 7 days before they got there first. So these guys have 2 ambulances and a supervised vehicle, but they're in the knife and gun club of Houston, and 6 hours after that, I think they have the record here. I don't know if anybody has gone quicker than that. And they had a second patient early that morning that could have used blood. So what's the plan here for the first team that gives blood?
Pat on the back.
Pat on the back. All right. So big question that gets asked, right? So blood really is started in HEMS, right? It has the critical care team that gets out there. The most critical of our patients across the U.S. in the trauma system have typically been picked up by HEMS and you get to trauma centers, so the transports can be long. they're typically not the first in responder. So we look at this and say, well, what about urban systems? This is our system up in Hartford. And San Antonio looked at this when they launched this as part of the data collection. They looked at a year and a half of San Antonio and Bexar County. This is pronounced Bear, Bexar is Bear. How long from the point of injury did it take to get somebody into the trauma center where they could actually transfuse? And they use the dispatch time as the point of injury. And on average, there's 2 level 1s in San Antonio. It took 28.8 minutes to get the patient who required massive transfusion to a trauma center. And I think this would hold throughout most cities. We didn't really do a study on it. Again, we didn't rebuild the wheel here or remake a wheel, but we went based on their data. It sounded reasonable. So the time to transfusion and the mortality risk has been elucidated in more than these 2 papers, but we tend to look at these 2 papers as sort of the evidence, right? As good pre-hospital providers, we always want to have some visibility about the evidence. Sometimes things feel right to do, but what evidence is moving us in this direction? So this first study was every minute counts the time of delivery to initial massive transfusion cooler and its impact. So things vary in trauma centers. Some trauma centers are allowed to carry enough to do a massive transfusion right away when the patient gets in the door. Some just have enough to get started and have to call for it to come by the cooler and the blood bank, and some are a hybrid of both. We have enough in our trauma center now to do massive transfusion, and we kind of carry it over when they get to the OR. I was hearing from you that MTPs are capable in the facilities.
They keep all the blood. They keep blood in the resuscitation.
Yeah. So that first unit, every minute that went by when they studied this in these trauma centers, there was a delay in getting the cooler and getting the patient transfused, that the odds of mortality on these MTP patients went up by 5%. This other study, looking at mortality in trauma patients with hemorrhagic injury from the torso, which is going to be a non-compressible, it is determined that this really occurs long before this concept of the golden hour. That the risk of death increased with longer pre-hospital times, and the most prominent risk of death is actually within the first 30 minutes. And then there's a degree of mortality that happens from time 0 to 15. So if you can't shorten that transport time to get this person in, then we need to bring things out to the field. And this paper that came out a few years ago, based on the military experience, and I always kind of qualify these military studies as it's not a heterogeneous population. It's usually young male, fit of life type of subjects. But I think it's a good starting point. Well, patients we're going to take care of could be on anticoagulation, may not be that young, healthy state, blunt versus penetrating trauma, so take all that into effect, or into consideration. But this looked at blood product transfusion pre-hospital during the medevac of combat casualties in Afghanistan based on 24-hour survival and 30-day survival. And what they found is that when the patients were transfused pre-hospital versus a matched non-recipient, meaning the injury severity was the same, but they did not get a pre-hospital transfusion, their probability of death was about 3 times higher than if they received a pre-hospital transfusion on the way in. That's a pretty compelling difference between these 2 subject groups. And out at 30 days, what we see is the bottom of the green line, the ones that got transfused. Yes, there was a higher death rate when we got out to 30 days because not everybody who survives the first 24 is going to make it out 30 with this level of injury, right? But you notice that the difference between the 2, that the probability of death remained the same on the ones that got transfused and didn't at 30 days. So it holds true in the acute phase on day 1 and at day 30 if they received a pre-hospital transfusion. Then they drilled it down a little bit more to say, okay, but at what point is there a timeline of how many minutes after medevac encountered them that they got transfused? Does that matter? So if their time to transfusion was less than 15 minutes, they stayed down here, and if the transfusion was greater than 15 minutes or they didn't get a transfusion, they had that 3-fold higher probability of death. And then when they looked at the patients that did get transfused, and they just split it out to 16 minutes to 20 minutes versus less than 15, you lose that survival advantage. So it's kind of compelling that we have to do this as early on as possible to do this hemostatic resuscitation with the blood products. It seems to matter acutely just in the minutes. So those of us in the real urban systems look at this data and say, it just makes sense, because in our day-to-day practice, whether a person arrived by a private vehicle or by EMS, we activate and do this very quickly. And if we can have our EMS teams do it, we consider the time that EMS starts that first transfusion, particularly with whole blood, because it's like starting the MTP, because they're giving plasma, platelets, and packed red blood cells at the earliest possible moment. There hasn't been a study out yet on the civilian side that kind of mirrors what happened there in that military experience. So this is a new national study that's supposed to be starting up this fall, that's going to run 4 to 5 years. It's looking at whole blood trauma patients, pre-hospital environment. Does it improve survival outcomes in 30 days compared to plasma, red blood cells, or nothing at all? Kind of like this Shackelford study. But we're not going to see results for 4 years, and I don't think any of us who are leaning into this in EMS would ever wait or change our practice at this point with it. But it will be good to have some additional data. So the wrap up on this is, most of these preventable deaths from trauma are from hemorrhage. Early control to stop it, the hemorrhage. Damage control resuscitation is a bundle of care. Stop the bleed, prevent hypothermia, balance blood-based blood resuscitation in the field. This pre-hospital transfusion with blood products are now a reality, but it does not supersede the basics of trauma care. Okay, there'll be ongoing R&D looking at some of these compressible hemorrhage sites. I just saw something this morning that was very interesting that looks like a Roboa catheter that actually goes in orally and inflates in the gastric area, which could be a huge game changer because it compresses the aorta down here at zone 2. And a Roboa catheter, if you don't know, is something that goes in. It's very difficult to place in a shocky patient, arterial, and you feed it up and inflate a balloon and have 3 zones. So we really need something less invasive, and they just put out the preliminary data on it. I think it's called a GOA or something like this. So any questions to this point? I know we covered a lot of info, and I appreciate your patience and attention to it. It's one of those things when you learn something new, this gives you the foundation. Go back, talk to teammates around here that have had experience with the blood products and everything, and I think that you'll ease into this, and when you start getting cases, it's just going to be so exciting in this department, because it certainly energized our department and our teams. We work very cooperatively. You're lucky you've got kind of an integrated air service here, but we work very cooperatively in our state. We've harmonized everything with our ground. We have one air service that unfortunately is based out of Massachusetts, which is so back-ass as far as allowing blood products. They haven't had blood products yet, so we've actually intercepted with them on some of their calls to provide the blood products to them until they get up and going. So anything for the patient. Do we need another stretch or? Oh yeah, absolutely, yeah.
So just a couple of points more low with less, and then we'll break one more time, and then do the life and song. So just a couple quick points. Of course, we're going to use the Credo ProMed cooler. I think LifeLink already utilizes this cooler. It has an internal tick, so there is if you look at the cooler itself on the inside, there is a plastic piece right here. It's a single unit piece that sits down and resides down in there. It was created and test driven by the 75th Rangers right here in our backyard. Is what we're going to use to help regulate and control that temperature. Every 12 hours we will rotate that tick out. There will be a tick that will stay in the freezer and a tick that will be in the pouch. So at both of the outlying QRV stations, we'll have a refrigerator and a freezer there, just a little dorm style. And so at shift change, you'll just rotate that tick out. I think Dr. Pettini already talked about these other pieces. I'll share the strap video with Dr. Jenkins. Really the big thing is the lethal triad. We're going to add the ready blanket, the ready-made, ready mat, I think is what it's called. Basically what it is, you open it up, and as soon as it comes in contact with the air, it starts to warm. And it's just a blanket that you'll put on these trauma patients. When you guys call, when you give blood to a patient, it will automatically be a trauma red. Okay, so we're not going to go through this huge big revision with trauma services and change all of the red and yellow. It was just a little bit too much to do. So the rule of thumb is just going to be, if you give blood, you're just going to say trauma red blood. Okay, and the downrange process that will occur is when they page it out, they will let the trauma team know that blood has been given to this patient. Anytime blood gets given to a patient pre-hospital, it elevates the level of concern for the rest of the trauma team that is a lot more severe than any other trauma red patient. So if you make the decision to give blood, it will automatically be a trauma red, and you'll just call it in as a trauma red blood. Dr. Pettini already hit on that. The morbidity and mortality numbers will improve. Each QRV will carry 1 unit of whole blood. In over 100 and, I can't even remember how many we had given in on-flow, 100 and something uses of whole blood. There was only 1 or 2 patients, I can only think of 2 off the top of my head, where we gave more than 1 unit of whole blood to the patient. And both of those were trapped patients for a very long extended period of time, and were basically exsanguinating. And one of them actually died before we could get him cut out of his vehicle. He got hit by an 18-wheeler and became one with the vehicle. So the supervisor will have 1. Most of the time, 1 unit will be sufficient. I couldn't really get this to blow up really well, just because